For the last topic of this session. The topic is diabetes with heart failure, how to manage. I invite Dr. Nitin Agarwal, who is a senior interventional cardiologist at Moradabad, to take the dais.
Thank you, sir. Thank you, Dr. Alok, for giving this opportunity and doing this kind of scientific activity regularly and improving every year. So my topic is basically diabetes with heart failure and how to manage it. Why we are talking about this topic, basically we all know that diabetes is a very prevalent disease and we all deal with diabetes. And when you deal with diabetes, you have to deal with cardiovascular disease. If you see this slide, this combination, cardiovascular disease and type 2 diabetes, it can present like three ways: diabetes or cardiovascular disease, or diabetes with cardiovascular disease and diabetes with CKD. So I would be confining myself to this category, that is diabetes with cardiovascular disease, and especially among this cardiovascular disease, heart failure. When you are dealing with diabetes and heart failure, how big is the problem? You see the diabetes burden in India in 2019, 77 million people with diabetes, and 2030, 100, and in 2045 going to be 134. And national prevalence of diabetes is 8.9%. So in a population of 100 patients, 8 patients are diabetic, 9 patients are diabetic, and cardiovascular disease is the major cause of mortality and morbidity in diabetics. So you have to look for CVD in diabetes. Cardiovascular disease and diabetes, we all know 65% of that are due to CVD disease, and complications are much higher. 2 to 4-fold increase in stroke risk, 2 to 5-fold increase in heart failure risk, and 2 to 4-fold increase in coronary heart disease deaths with diabetes. Life expectancy, if you see in a 60-year life expectancy, diabetes is reduced by 6 years, and if you've got diabetes with MI, it is reduced by 12 years. So you lost major years of your life with diabetes and CVD. This is important that as your population grows older, in diabetic individuals, heart failure incidence grows more, and this graph get diverged. So as you are dealing with geriatric patients, you have to deal with heart failure patients in diabetic as well as in non-diabetic individuals. Coming on to the cardiovascular involvement in diabetes, this is important that heart failure is one of the earliest CV complication in patients with type 2 diabetes, even occurring before MI and stroke. So whenever you are seeing a patient of diabetes, you must look for symptoms, or you must look for heart failure in diabetes. You have to screen them to look for heart failure. Coming on to this slide that shows that whether HFrEF or whether HFpEF. With diabetes, mortality is high. With diabetes, incidences are high, and diabetes make it worse in both of the situations. All-cause mortality is increased in both of the situations, whether HFrEF or whether HFpEF. So, is diabetes a risk factor for heart failure, or heart failure is a risk factor of diabetes, or relationship is bidirectional? We usually think that diabetes comes first and then heart failure comes, but we have got evidences that heart failure patients are also likely to have more incidence of diabetes. Diabetes as a risk factor for heart failure. In Framingham heart study, diabetes was associated with nearly 2-fold increase in risk of incident heart failure, and various studies are there which says that with each 1% increase in HbA1c, risk of incident heart failure increases by 8 to 36%. And heart failure as a risk factor for diabetes, there are studies which shows that among non-diabetic patients with heart failure, studies in various programs, there was higher incidence of getting even in non-diabetic patients heart failure, more chances of getting diabetes. So whenever you see a patient of heart failure, you must follow these patients meticulously to look for development of heart failure. Maybe sometimes it is due to drugs, maybe sometimes it is due to the milieu which the heart failure patient is there. So if you see these two overlapping epidemics, heart failure and type 2 diabetes, when you are dealing with heart failure, there are 30 to 40% of patients with heart failure who have diabetes, and you can say that heart failure is a kind of dysglycemic insulin resistant state. In a heart failure, there is a kind of insulin resistance, and this increased risk of hospitalization and all causes death with elevated HbA1c. And when you deal with diabetes, it's already a risk factor for development of heart failure, and worse glycemic control is associated with worse heart failure. And when you have got these both, patients with have both heart failure and diabetes have a very poor prognosis. So coming on to the pathophysiology, where there are various things why diabetic patients get heart failure. First is atherosclerotic cardiovascular disease, dyslipidemia, endothelial dysfunctions, getting coronary artery disease, ischemic cardiomyopathy, and heart failure. But this is also important that those patients who are not atherosclerotic cardiovascular disease, only diabetes leads to cardiomyocyte hypertrophy, RAS activation, and some abnormality in calcium handling, fatty acid utilization, autonomic dysfunction, and that all leads to diabetic cardiomyopathy. So you are dealing with diabetes, you are not dealing with atherosclerotic cardiovascular disease, and you are getting heart failure because of diabetes. Coming on to the staging of heart failure with diabetes, we all know that 4 stages. Stage A, when you are at risk of development of heart failure, obesity, hypertension, hyperlipidemia, kidney disease, coronary artery disease. And in stage B, when you are having some kind of structural abnormality, you are finding with echo, either systolic dysfunction, diastolic dysfunction, hypertrophy, chamber enlargement, valvular disease, or some kind of increased filling pressure, maybe by biomarkers like NT-proBNP. So it is said whenever you are dealing with a heart failure, with diabetic patient, you must check his NT-proBNP levels. If the patient is asymptomatic, get NT-proBNP levels, and if they are raised, look for other parameters in echocardiography, and you let them to be stage B heart failure patients. We all know stage C or D heart failure, symptomatic patients having heart failure symptoms, and like exertional dyspnea, orthopnea, PND, weakness, fatigue, and weight gain. And we have to prevent patients reaching to this stage in C and D. If we can diagnose in stage A and B, we can give some kind of intervention, some kind of treatment, so that we can prevent them to go into C and D, and then overt heart failure or advanced heart failure, so that you can reduce them. So this is a diagnostic algorithm. Whenever you see a patient with diabetes, he is already as a risk factor of heart failure. Ask for symptoms, look for signs. If they are present, go for echocardiography. If it is abnormal, it is stage B. If it is normal, if it is go for NT-proBNP. If it is raised, it is stage B. If it is normal, it is stage A. Even in stage A, you have to look for other risk factors so that you can control these risk factors to go into heart failure. And whenever you see a patient with stage C or D, you have to classify them with either HFrEF, that is EF less than 40%, or mildly reduced, that is 41 to 49%, or more than 50% is HFpEF. And then after doing this algorithm, you have to treat these kind of patients. Now coming on to the treatment goal, it is very important to see that if you are having in which stage of diabetes. If patient is already advanced stage of diabetes, HbA1c levels are very high, and they have spent more than 10 years of diabetes, then in those patients treating them very aggressively may not be a very good thing. They may have episodes of hypoglycemia, and you may increase the mortality. So you have to stage your patient of diabetes. If it's a young patient, stage A patient, less duration of diabetes, you have to treat them aggressively. You have to keep their HbA1c level aggressive levels. But if the patient is basically stage C, stage D, comorbidities, you don't treat them very aggressively. It's a kind of U curve. So you have to see as you go low in HbA1c in these patients, you increase the mortality. You don't have to go very low, you don't have to go very high. You have to keep the HbA1c level between 7.1 to 7.8 in those patients who are stage C and D and advanced diabetic patients. So you have to see that if a patient is an advanced diabetic patient, don't treat them aggressively with drugs to keep their HbA1c level to very low. Go for 7.1 or 7.2. This is a slide which basically shows that if the patient clinical functional status, self-management capacity, social support, look for hypoglycemia risk, treatment burden, and then decide whether you have to go for 6.57% or you have to go for 8 to 8.5%. In stage D heart failure, end stage kidney disease, multiple comorbidities, uncontrolled cancer, don't go for aggressive control of sugar levels. Treatment according to stages. This is a classification where stage A, stage B, stage C, and stage D, and how to manage these patients. In stage A, you have to have basically a primary care, dietitian approach, endocrinologist approach, look for history, physical examination, periodic evaluation with BNP levels or high sensitivity cardiac troponins. So these two markers, high troponin, high sensitivity cardiac troponins, and NT-proBNP levels, you have to see in stage A and stage B levels, and you have to look for heart failure. And then when you progress from stage A to stage B to stage C, your treatment progresses accordingly. So coming on to the stage A, if you see the medical management levels, we all know we have got in stage A, what we have to do is we have to control the risk factors. Patient is having hypertension, go for ACE inhibitors or ARBs, optimize blood pressure controls, optimize his lipid level controls, And now in stage A heart failure, diabetic patients, if you want to prevent heart failure, we have got good medications like SGLT2 inhibitors, where we can optimize the glucose control and we can reduce the chances of heart failure, developing heart failure. So SGLT2 inhibitor has come up in the last 3 or 4 years to a very increased level, and you can use in every diabetic, you can use in non-diabetic, you can use in at-risk diabetics, you can use in heart failure non-diabetic patients. In stage B, similarly to stage A, ACE inhibitors, SGLT2 inhibitors, you have to avoid those medications which may precipitate heart failure. So pioglitazone, DPP4 inhibitors. DPP4 inhibitors are basically of no use if you see cardiovascular benefit in treating diabetes. So first choice should be SGLT inhibitor, and then you can add on DPP4 to control the diabetes sugar levels. Otherwise, for cardiovascular benefit, they are either neutral or they have given bad results. So avoid them, avoid thiazolidinurons, and avoid sulfonylureas if you are concerned for cardiovascular disease. Yes, they are basically used in low doses and they are beneficial in reducing the sugar levels. So ACE inhibitors, ARB, are preferred agents in management of stage and stage B. Treatment with thiazolytic type of diuretics or an ACE inhibitor has been shown to be more effective than treatment with calcium channel blockers in preventing progression to symptomatic heart failure. And their use is recommended for treatment of individuals with diabetes and hypertension. Among patients with diabetes and kidney disease, now we have got a molecule like finerenone, which reduces the progression of diabetic kidney disease. So whenever you have got a patient of diabetes and you have got a patient of kidney, then you can use this molecule where you can avoid progression to diabetic kidney disease, and even you can avoid progression to heart failure. Figaro DKD trial. And careful monitoring of serum potassium levels must be there whenever you are using MRA and RAS blockers. So this slide basically shows what you have to do in stage A. Patient is hypertension, optimal control of blood pressure. Patient with diabetes, go for SGLT2 inhibitor class 1 indication. Patient with CVD, you have to optimal management of CVD management. Patient who have got exposure to cardiotoxic drugs, you have to look for heart failure development. And patients who have got first degree relatives with genetic or inherited cardiomyopathy, you must look for those things, and genetic screening can be done in these kind of patients. Always try to check natriuretic peptide levels every 6 months in those patients who are stage A, and patient at risk of heart failure. You should have a multiple variable risk scores. You can calculate the risk scores and you can treat them aggressively. In stage B, of course, ACE, ARB, beta blockers, and if patient is having less than 30% EF, we can go for ICDs, and for non-ischemic cardiomyopathy, we can go for genetic counselings. In stage C, and if you are dealing with a stage D heart failure patient, you have to see that whether we have to treat them aggressively with diabetes or not. If a stage D heart failure patient, don't treat them very aggressively. Treat them for symptoms, treat them for comorbidities, and keep their life easy, and possible heart transplantation and LVAD devices, and send them to heart specialist treatment. And we have got certain other molecules also where like isolazine, hydralazine nitrates, especially in Asians and African Americans, ICDs, CRTs, and all those things which we are dealing in FREF and FPEF studies. So 4 pillars we all know: RAS, beta blockers, MRA, loop diuretics, and SGLT2 inhibitors. Coming on to the recommendations, class 1A indication for SGLT2 inhibitors like DAPA, EMPA, and SOTA. And coming on to choice of DAPA, EMPA, or SOTA, you can choose anyone. But yes, dapagliflozin and empagliflozin are being used in various trials, and they are the first choice. Then coming on to ARNI, we all know over ACE inhibitors and ARBs, we need to use these molecules. And beta blockers, we should use these molecules like beta blockers in almost every patient if there are no specific contraindications. Then coming on to the initiation of evidence-based treatment, this is the strong HF trial which says that you start with aggressive treatment. Don't wait, don't add one molecule, wait for 2 weeks, add second molecule, wait for 3rd week, 4th week, 6th week. You start the aggressive treatment according to the guidelines, and you give them a good dose, and you escalate your dose in 2 weeks or 4 weeks time, so that you can reduce the mortality in long term. So you have to treat the patients aggressively. If you are implying these best practices and these algorithms, then with these kind of molecules, you can reduce mortality in heart failure patients, in diabetic patients, and This SGLT2 inhibitor, I must say, is a wonderful molecule. Once daily dose, no need for titrations, very few side effects, and you must use this SGLT2 inhibitors in almost all the spectrum of heart failure patients. You can reduce the mortality. You see by this slide that quadruple therapy with these molecules, ARNI, beta blocker, aldosterone antagonist and SGLT2 inhibitors, number needed to treat is very low. You can have a 26% absolute risk reduction in these kind of patients, and number needed to treat is only 3.9. So these fantastic 4 molecules, and to these fantastic 4 molecules you can add anticoagulants, digitalis, your CRT, ivabradine, loop diuretics, verisoguard, according to specific indications. You can you must look for anemia. You add ferric carboxymaltose, and you can have hydralazine nitrates, especially in Indian patients. Those patients who are not responding to these treatments, and now minimally invasive surgeries, mitral S2H repairs, and these invasive surgery can reduce morbidities in these kind of patients. Coming on to the various molecules, DPP4 inhibitors, not very much beneficial. Thiazolidinediones, at all, they are to be avoided in heart failure patients. So I give this talk an end, and I say that to reduce heart failure related outcomes in all patients of type 2 diabetes, whether HFpEF, mildly reduced, or HFrEF, SGLT2 inhibitor is first choice now, and then you add on other hypoglycemic agents to control sugar levels. First choice is SGLT2 inhibitor in diabetic patients, especially when you are dealing with heart failure. Thank you.